So our first presentation appropriately is from Dr. Jane Messina, our lead dermatopathologist, and she's going to help you understand your pathology report and how we use it for treatment. Okay?
Thanks. For the Zoom or Facebook, does it matter where I stand? I have to stay in the middle? Yep. Okay. I'll probably be looking back at the screen. Thank you so much for the opportunity to talk. I always appreciate the chance to show how important pathology is. And I appreciate the central role that we're given in the care team here. So I hope I try to show what pathologists do in a way that's digestible for people who have no pathology or medical training. So I hope I'm at least partially successful. I also like to know who I'm talking to, and if you're comfortable answering, I would love to know how many people in the audience have had melanoma personally. Wow. And how many have had a loved one with melanoma? And the above. None of the above.
Yeah.
Well, thank you all so much for being here on your Saturday. A lot of times I start this talk out with reference to a show, and usually the last time I gave it, it was CSI, dissecting the clues to figure out what you have in pathology. But this particular talk is more appropriate. Is it Knives Out or not? Because I'm going to talk about the role we play in determining further treatment usually by surgery in early melanoma. And one of the things that's very confusing, even on a medical level, is the number of new tests, all of which seem to have a new fancy acronym. And I'm going to hope to kind of demystify some of these tests that you may have heard about, some of which are listed there. I'll go through all of these. And so briefly, the objectives that we're going to do in the next few minutes is to talk about the impact of melanoma on society, the numbers, what happens when your physician suspects you have melanoma, how is your melanoma specimen analyzed, and what are some newer things that we're doing to help understand the diagnosis and the disease. Just kind of the impact, a lot of the numbers that we give are US, and a lot of the statistics we have are for non-Hispanic white people, so rather than global numbers. So this is the number of white Americans, 1 in 28 non-Hispanic white Americans that will develop melanoma in their lifetime if they're male, and a few less if they're female. But really that pales in comparison to how many will develop skin cancer in their lifetime. As Dr. Samek alluded to, it's considered to be altogether equal to all the number of other cancers combined. And to think about melanoma, you have to put it in the context of the whole epidemic of skin cancer in the US, the majority of which is the non-melanoma skin cancers or the keratinocyte cancers, if you like to give them a positive terminology, the squamous and basal cell carcinoma. And I think I left out the numbers here. Oh, no, there they are. Hard to get an idea of the incidence because they're not reportable. But it's estimated over 3 million basal cell cancers and about 1.5 million squamous cell cancers compared to the 186,000 melanomas.
Joe Biden just had a basal cell.
Pardon?
Joe Biden just had a basal cell cancer.
Yeah. And Jill, right?
Joe.
Joe just had one
Joe
taken
just
off
had
his
one.
chest today.
So yeah, they're the perfect phenotype. So that was the number of new cases. And in terms of the number of deaths, that's also very hard to estimate. We would all love to know how many people actually get non-melanoma skin cancer and die of it. I feel like we see an inordinate number of those cases here because it has a reputation of being less aggressive, but really takes an incredible toll every year. But melanoma, it still accounts for about 2/3 of the deaths from skin cancer. And, not just talking about the numbers, but also the cash. It is a humongous part of our national healthcare budget to take care of skin cancer. So does anybody want to just think in your mind, how many people in the US do you think might get treatment for skin cancer a year? And these are about 5-year-old data. That's a humongous number. And the estimated cost, $9 billion, which is 10% of, 10% of all of our total cancer expenditure. It's a huge amount of money. Luckily, or positively, to decrease this impact, the earlier you get it, the longer you live, and the easier it is to treat. So if you have, if your melanoma is not spread at the time of diagnosis, you have up to a 99% chance of still being alive in 5 years. This drops to about 60, and actually those are older figures. I think we'll hear better and more accurate figures about how long you live now if you're diagnosed with stage 4 disease. The good news is most still, about over 80% of melanomas are diagnosed when they're still localized. I'm sure everybody's seen a version of this. We don't have to belabor the ways to pick up the most classic melanomas by the ABCDEs, but we still realize that melanomas, there's a subset of melanomas that are completely inapparent. Both of these images taken offline look, one on the left looks like an intradermal nevus, the one on the right looks like some type of rash. These are both melanomas. So it's still some cases are slipping through, being diagnosed at later stages, and we're looking for ways to identify them earlier and earlier by non-visual techniques, because we recognize that depending on your level of training, even the best, most experienced practitioner, the dermatologist, has up to, at best, an 80% chance of recognizing a lesion as melanoma. That means like 1 in 5 lesions that are melanoma, they may not recognize as melanoma. So it's a lot of, we have a very low burden of evidence to perform a skin biopsy on things that even remotely resemble melanoma. And that's a huge amount of skin biopsies. It's a huge amount of that healthcare expenditure. And a lot of these biopsies are going to be negative. It's estimated that up to 90% of biopsies that are done with a rule-out melanoma or rule-out atypical lesion have non-melanoma diagnoses. So one of the newer tests that's come along is the pigmented lesion assay by DermTech. And that's a non-invasive way by using a little circle of sticky tape to sample the surface of a lesion, which peels off some genetic material from the lesion, and it's sent to the lab, and it's analyzed for the presence of genetic material for RNA, some 3 types of nucleic acid. If one or more of these markers are present, the test is called positive, and it's supposed to indicate the presence of a higher risk lesion, either a melanoma or a lesion that called severely dysplastic nevus that is typically excised and needs to be excised. And this is what a typical report looks like. This is off their website. If one marker is positive, then it gets a yellow caution. If 2 markers are positive, it gets high risk, and yellow and red lesions will be biopsied. And if one or more markers are 91 to 97% of unequivocal melanomas are positive for the pigmented lesion assay. So yeah, if you recognize it as melanoma and test it, you're good. There's some issues with, a lot of issues actually with false positives. So 42% of benign lesions are also positive for it. And also about 15% of the time when you do the test, it comes back, we didn't get enough material, and it either has to be repeated or you just go ahead and do the biopsy. And the cost of the test is about twice the amount of the biopsy. So this has been increasingly done, but it's we don't have a large healthcare system strategy for how to integrate it in yet because of the cost and because of these issues with a lot of false positive tests and the tests being inadequate. So if you go to get a biopsy, I see that almost everyone in this room has experienced one or more versions of the way to sample a pigmented lesion. The shave biopsy is by far the most commonly done because it's quick. It can be done in the office immediately. The books will say an excisional biopsy, young man, when you're taking your boards, they'll say excisional biopsy is the best way to diagnose a pigmented lesion, but that's not practical in the course of a busy clinic. So the lesion will be removed in the office, put in the jar, sent to Dr. Sondak, and they'll start waiting for my answer. And I have some slides to show you what actually happens to the biopsy after it goes to pathology. It's a multi-step process. For all of the techniques we have now, it's still extremely manual and many people touch the specimen. So the first day it's touched by a pathology assistant who places it in a plastic container. The container goes into a thing that looks like a little, like a dorm refrigerator size processor that costs about as much as a minivan, sits there for 8 hours. And then it's removed, it's taken out by a histotechnologist who cuts 3 micrometer size slices of the specimen. It's put on the stainer, it's put on a slide, and then finally it comes to us. And so when we get a lesion that's suspected of melanoma, we need, first of all, we need stuff from the doctors on the report. We need to know how, these are all things that help us do our job better. Has the lesion changed recently? How big is it? What did it look like? Was there a previous biopsy? That's really important. These can all influence the way a lesion looks. Obviously, name, age, sex, and location are required. And then our contract is, well, we got to get the diagnosis correct. If it's a melanoma, we need to give them information to guide the treatment and prognostic information if possible. But correct diagnosis, here's how we're going to do it. And then we produce a pathology report. It is important to note on the signature line of your pathology report whether your doctor is board certified as a dermatopathologist, but that's by and large in the US in metropolitan areas, that's 100% of skin biopsies are looked at by a board certified dermatopathologist. Notice that this is a report of a melanoma. There's a lot of things going on here besides just the M word. So I'm going to show you what are some of the things that we do to decide if a lesion is melanoma and how do we assess it. So the first things we do is under the microscope is assess ABCDEs of our own. They're very similar to what you've seen for deciding if a lesion is clinically melanoma. So we can see asymmetry under the microscope. If you divide a lesion in half, one side is often bigger, more cellular, or different looking than the other. We can see the irregularities of the border. All these little vacuolated cells here are melanoma cells. And it's really hard, this purple line is skin. It's really hard to tell where the skin starts and the melanoma stops. If it was benign, it would be a straight line. We can see the diameter of it. If we put it under the microscope at low power and we can't even see the edges of it, that's big and scary. And then we look at other things such as it's not a color, but it's confluence. This is a melanoma done with a special stain that we'll talk about in a minute. And all the red cells are melanoma cells. They're all connected in a line. That's confluence, that's bad. Ugly cells present at all levels of the skin or epidermal upward migration is also bad. A lot of times we have to analyze lesions in a way other than the typical pink and purple I was showing you of. That's when you may see in your report immunohistochemical stains were done, and they all have these acronyms. And these are some of the most common ones that we use for melanoma. These show us the presence of antigens that are proteins that are on the tumor cells that are in some way sensitive and or specific for what type of cell it is. And so as unique to melanoma as we can possibly get. Other things that are done in lesions that are very difficult, don't follow the ABCDE rules, or don't follow the rules for staining us, for the stain positivity, include fluorescence and high situ hybridization. And that is a test that looks for extra copies of genetic material on a slice of the biopsy. It's done in a specialized lab. Here we order it from a commercial lab in Fort Myers, Neogenomics. And it's pretty, even in lesions that are not obviously melanoma, it's pretty good at picking up melanomas. It'll be positive in about 90% of obvious tumors. This falls to about 50% in more tricky lesions. So, we're not going to send a lesion to them that's not, per se, tricky. So you can't always take the result. You sometimes have to take the result with a grain of salt. So you have a bit of a false positive issue with FISH in some tricky lesions. But I use it sometimes. Another test that has become widely used, I've seen in private practice. We don't use it here because most of the time patients come to us already with the diagnosis of melanoma. But that's the gene expression profile test. It started out as MyPath, and now there's a new iteration called DiffDx. And these analyze in a slice of tumor for the presence of either 23 or 35 genes. And again, this test works great on unequivocal melanomas. It works pretty well on unequivocal benign lesions, but it hasn't been adequately tested either in the lesions that really give us agita as pathologists. This is what a DiffDx report looks like, or as I'm old, it gives you a score. If the score is negative, it's most likely benign. If the score is a positive integer, it's most likely malignant. And all of these things guide what happens, guide the dermatologist in performing a subsequent biopsy. One of the most, which is just a brief mention about the trickiest lesions. This, I see we all have a group of mature adults here. The most tricky lesion actually occurs in in adolescents or young adults, and those are lesions that are in the spitzoid realm. These are lesions that resemble a benign lesion called a Spitz nevus. And in these lesions, under the microscope, there's so little difference between what's completely harmless, and a lesion that may have the potential to spread. I'll show you an example. Even if you're not a pathologist, you can see wow, these are two different lesions. They look kind of similar. Maybe the one on the right's got a little bit more pigment than the other. One of these is completely benign and the other one spread and was lethal. And that it was not the one on the right, which to me looks worse. It was the one on the left. So there are these lesions that are very tricky. And we have actually very powerful test that unfortunately is still quite expensive and not quite widespread. And that's next generation sequencing, where they actually sequence and can detect mutations in up to 500 genes and other RNA transcripts within a lesion. And some of the examples are Foundation Medicine. That's probably the most commonly one done around the US. Caris is another one that may be recognizable. Here at Moffitt, we have our own acronym, the Moffitt STAR test. MSK, Memorial Sloan Kettering has their own. This is more for the medical audience, but it sort of shows how we integrate all of the acronyms that I talked to you about into a pattern of analyzing them step by step to determine if a lesion is benign or malignant. So now we've come to the near end where we've decided that a lesion is in fact melanoma. So here is again that example of a biopsy report showing melanoma. I showed you, you've got this really long column of things here. What is this? These are the prognostic and staging features There's a lot of them, but really the ones that really matter are the tumor depth, the presence of ulceration, and the presence of microsatellites. And those three aspects go into the final staging of the lesion. Here's what they actually look like. The Breslow depth is when we have a little ruler in our microscope and we put the 0 on the top of the skin and we measure the bottom of the melanoma. Ulceration is when the epidermis, which is that purple line on top, is completely gone over the surface of it. And microsatellites are super rare. They're when, here's the main body of the melanoma, when you have a piece of melanoma that's completely separate from the main tumor. And those all confer a worse prognosis. We add those findings up to produce a T stage, or in the case of satellites, an N stage. And then Dr. Sondak knows how much normal skin to take off around the edge of the lesion when he removes it, as well as does he perform a sentinel node biopsy or not. So thank you for sticking with me for this. And so I hope at the end of this, you understand a little bit more about how many people get melanoma and what happens when one is suspected and how we look at them and guide further treatment. Thanks for your attention.